right, so go ahead and inject.
It looks like he's in perineal. Not really sure why he would wire the perineal.
And I hear whispering in the background, and I'll answer that question in just a moment.
We're just curious, Chris, just curious whether you're in the wire in a perineal or a PT, but we take your word for it. You said it was in a PT.
Oh no, I'm sorry. The tibia perineal trunk, and I misspoke, so you're right. It's in the big perineal. So you see the nub of the posterior tibial, but we did not wire that. I wanted to get your advice, and I think Tony's right that we fight that another day if we need to. So, all right, ready?
That was me whispering whether or not my eyes were deceiving me. I've been called old already today, twice.
You know, Chris,
no way, Tony.
I'm getting sensitive.
You guys gonna hug it out later. Hey, Chris, will it be possible for you to show us a foot angiogram prior to do any interventions with runoff to the toes?
Absolutely. Yeah. Did you see the runoff? You mean we did? I'll show that to you in just a sec.
Sure.
So tell me when you see the device, please.
So interestingly, the wire bias there looks like the angle has become less severe, significantly less severe.
Isn't that the truth? And so I think really any of the atherectomy devices are on the table now, quite honestly, because I think you're right. It's amazing how things change when you go live. Before it looked calcified in a 90-degree angle, followed by another angle with a wire in there, it really looks pretty smooth, like case we'll do later. Where are we?
Yeah, like what are you worried about?
Yeah, exactly. And so, I don't want to hear any sissy things up there from the panel, please. All right, so let's do two things. We'll take a picture of this right before we do it, but Jihad, let me show you the runoff to the toes here. All right, so here's the initial runoff.
So what we try to do is look at the hyperemia or the perfusion of the ulcer location pre-intervention, and then look at it post-intervention. And what you expect to see a significant hyperemic phase if you have good perfusion into the ulcer location.
Okay, can you see
what
that?
What do you use to assess that, Jihad?
We focus a lot on TBI or PPG if we can. If not, we do late phase filling of the angiogram with lateral and AP view of the foot.
Stay there, okay.
Can I ask?
So you see the runoff there?
The perineal has a great collateral anterior, right?
Really does.
I mean, you can drive your car through that collateral. So, do you think that the pressure gradient? Why does he have an ulcer with this perineal? Should it be something to the? I know that you IVUS the tibial perineal trunk, but should there be a lesion to the tibial perineal trunk? Is the problem?
I can see why this guy has an ulcer. Actually, if you look at the PT filling, is actually very scarce, and I'm not sure if the ulcer is in the plantar aspect or dorsal aspect of the foot. All
right, so let me do this for you. Let's do a picture right now. Oh, nice and still for us. You're doing great. And I'm going to mag up so we get in the right place here. Where's our? Okay, I see it. All right, ready? Okay.
So, Chris, don't tell us the size of the balloon that you're using. Just looking at this angiogram so far. Rich, what size balloon would you use in this AT to perform angioplasty?
I would. My feeling is you can always make it bigger. You can't make it smaller. So with that angle and everything, I would start with probably a 2 or maximum 2.5 balloon. And if I was going to balloon it alone, I'd probably use a focus force balloon.
What balloon? I'm sorry.
Pardon me?
Which balloon would you use if you were going to?
Use an angiosculp.
Angiosculp, okay.
I would agree that some kind of scoring would be useful here. I mean, we have our own preferences. I would probably use a chocolate balloon here. I think it would make a very nice result, and take the balloon into the distal popliteal across that bifurcation and not try to just nail the bifurcation, because I think the split actually happens from there. But just the registry that was done, looking at the chocolate bar registry, there really was a very significant reduction in dissections compared to plain old balloon angioplasty, and using a slightly longer balloon and sizing it up. I would probably use a larger balloon than a 2. I would probably use something like a 3 or even larger. The 3 for sure, and cross that ostium, because you don't really have much osteal disease of the TP trunk below it. What are you using, Chris?
All right, so after those discussions, these are all excellent points, and again, speaks to the integrity of the open discussion of the panel on all the options. I like the chocolate balloon a lot also. We also like VascuTrack. What we have chosen here is a 306 cutting balloon. The reason for that is there's some disease downstream that's not bad by IVUS. And if I took anything else, a chocolate, a VascuTrack, or anything else, we would have to go around that curve and get into that other disease. I'm with Tony that I think we want to treat that osteo lesion, which is mainly where the problem is, and we're going to pull it back. You can see on our images there, and we've got a 306 cutting balloon, and we're going to go up very slowly with that and let it sit there for a while.
We know it's a 3.0 vessel at least by IVUS.
The vessel
All right,
was
so
3.0
does
by
everybody like
IVUS?
that? Yes.
Great.
All right, so I'm going to go up slowly if everybody likes that position.
So Chris, you're saying that when using chocolate balloon in this area, you go slow, and when you, what do you?
I think. Go ahead.
Yeah, what do you mean by that? Is probably take about 30 seconds to get it up to nominal, or longer than that?
You know, I think longer than that, and I'm really known in this lab for my patience. So I usually let the tech do this because I'm not known for patience. I'm glad that they didn't break into open laughter. But yes, I really do believe that 1 atmosphere at a time and then a prolonged inflation. And so that's, right now I'm still at 4, 5, and again, they're making me here. Mark's saying he's counting 1 Mississippi under his breath. You can't hear him, and I appreciate that.
You know, Chris, I totally agree with you, and you're doing it for a good reason. A perforation at the ostium of the AT is really not a good place to have. This is definitely a devastating location to have a perforation. So your technique is absolutely phenomenal for this specific lesion.
You know, to just throw a little controversy out there. All these balloons, Angiosculpt, the chocolate, you know, I believe they work. I believe they're better than regular balloons. But also, if you notice, Chris is talking a lot about technique, slow balloon inflation, 1 atmosphere every 10 seconds or so, which is an art that we actually lost with regular balloons. You know, in the corny days when all we had balloons, we did long, slow inflations and got great balloon results. So I think it's worthwhile asking for all these balloons, how much is it of the result is due to the balloon technology itself, and how much is due to proper balloon technique?
That's a good point.
Well, you know, in chocolate bar, this is exactly what we did. We went up slow and stayed up a little bit longer, and that probably has a merit to why we have such a low dissection rate.
Yeah, so how long is long? So, you know, for
The length of 1 joke.
exactly. So, you know, for us, it's 3 to 4 minutes, and I think that generally works, but it's things like this where you really want to stay up as long as possible, as long as you can tolerate it. I think that, you know, 4 or 5 minute inflation. It's really a hard thing for live cases, but it seems that the best is optimal angioplasty, is really this long-term angioplasty.
I agree. Average balloon inflation for me is 3 to 4 minutes, or longer. And it's not like they're coronary and they're getting ischemic and hypotensive. But even in the old days, we had perfusion balloons. We would do 20 and 30-minute balloon inflations in the coronaries.
Oh, the good old days.
So Chris, assuming this looks great when you're done, so you leave it alone, but what if you have a spiral dissection here that you end up tacking up and it doesn't work? So what would be your backup plan? It's not going to happen.
I'm going to ask you to go to another lecture. And so if that happens, you know, that's a great question. Now, I think with this favorable wire angle and the importance of the anterior tibial, I would consider, if it doesn't, I would first try to tack it up. If that doesn't work, we would think about I would think about the shortest drug-eluting stent that would cover the action there. I think we know the restenosis rate for, say, an expert stent or a nitinol stent down here. You know, you might as well just, you know, it's going to come back. So I would probably put a drug-eluting stent if it wouldn't tack up. What do you guys think?
You know, I would do what you said, but probably would use a longer drug-eluting stent. And we've learned so far, if we go up past the angle, which is at the level of the takeoff of the anterolateral branch or the retrogenicular branch, it's a good idea to cover those to give you a straight segment. So the tip will be distal to that, back to the ostium.
Yeah, I think you're right, and that's what we would do. So in Well, let's take this out and see what we got here. So we'll see if we have to answer that question. What I'm hoping I'm going to show you is it's going to look beautiful, and then we'll go to the next stage of the intervention. But time is going to tell, as is this next angiogram. Do you have the nitroglycerin on the table?
Some nitro.
Now, let me ask, as we're thinking here and waiting for this picture, our plan was to use the large jet stream device, not in the aneurysm, obviously, but for the plaque above there. Now, to your point, Tony, if that looked beautiful with that and angioplasty, maybe we could avoid the Viabond stenting, okay? And if that didn't look beautiful, then we would proceed with the IVUS-guided Viabond stenting. So let's go to lower leg. So think about that and give me your thoughts on that in just a sec. Is that... Okay. All right, so we're going to get a picture for you, and everybody cross your fingers here. So it's, we always hope for a picture that's going to give you an ooh and an ah. I don't think we got the ooh-ah factor.
Ooh.
Although we did not, I think the osteum, somebody whoever helped me out there, I appreciate that.
Chris, can I give you an advice?
Picture.
I'm going to give you one advice today. That's it. I would actually take a 4O balloon. I know it's a little bit aggressive, but it will work. 4O balloon to 4 atmospheric pressure for 2 minutes. Take it down beyond the, take off the interlateral branches, so maybe 4O by 60. And
all right.
I know you're not supposed to listen to the panel when it comes to suggestions, but give it a shot.
If anybody I'm going to listen to, at least consider, it'll be you. So let me take an angulated view, and then we'll consider that. And if so, let me ask you this: as we're preparing, can we then go to at least a focal force balloon or not? Okay. And then I'm going to ask you why we're going to do it, though.
You know, that lesion at the takeoff of the genicular branch, when that branch is coming up, that lesion is really tight. I would not leave that one alone. And actually, if you take a picture distally, Chris, let's see if the AT is now filling integrated on its own. Maybe that's a good argument then to leave it alone if you're thinking of that.
Hey guys, while we're doing that, grab me a, let me look at that last picture. Grab a 3, I may compromise with you based on our IVUS, and either go with a 4.0 balloon or a 3.5 scoring technique. So 1, 2, let me have a 3.5, 40, and a 20 vascular, okay? Open those. All right, so let's do what you wanted there, Jihad. Let's take a look downstream, remembering that what we have here is a hand injection from a guy with a C7 nerve root, not our power injector.
It's a good thing that you don't have to do really delicate work with that right hand right now.
You know, it's amazing that, you know, for EVARs and carotids, they're pretty good for below-the-knee stuff. I'm going to turn it over to my junior partner here for a week as I recover. Can we get this camera moved down? And let me get Mag up one and see if we can get it. Okay. All right. Do me a favor, sir. We're going to take a picture of this right foot. I'm going to ask you to hold it nice and still for us, okay? Nice and still. And again, this is just 8 cc's. I got to say, I think, even with a Metzger gram instead of a power injector, Jihad, and I can show you the other one to begin with, but remember how before the perineal vessel really came down? Look at that anterior tibial. It's lighting up a lot quicker than it was before.
Yeah, it is filling quicker. Usually the way we measure it, you see that lateral branch coming off the perineal. If the AT fills before that, then you have a direct flow into the ischemic segment, so directional revascularization. You know, Chris, this is looking so good. As you get in prepared for the next segment, what's your thought on doing antegrade access and revascularization of a CLI patient like this patient?
Okay, so this afternoon, stay tuned, we will have an antegrade. And we thought about this. I won't go back and show you again, but it looked like on the initial pictures that Mark took that there was disease in the ostium of the SFA. And what I didn't want to do is inhibit inflow, because we need at least a 7 French sheath here if we're going to put Viabond stents in. And so that's why we didn't go antegrade here. But I think that's a great point. For our case today, we will for sure go on antegrade because we have to get to the foot in a 6'4" gentleman. I think that's a good, it's a good point there. So looking at this picture here, do you want to hit this or do you want to go on to the next phase of the case?
I vote for treating this.
I'm sorry?
Did you ask us if you should treat it or move on?
Treat this further or go on to the next phase of the case?
I would treat this for sure.
I would treat that
Okay.
also. The AT is tight beyond where you've already dilated.
All right. Why don't we take a 3-5-20 vascular track? All right, we'll do that, and then what we're going to do after that is drop our NAV6, and that's why we've got our wire in place already, and then we'll get to work on the rest of it. So let's go back up and roadmap this.
So Chris, I want to share with you, the struggle that we're going through right now with drug-coated technology and tibial trials and revascularization. One thing that we're doing is we undersizing the balloons to vessel diameter ratio significantly. I think probably we ought to do maybe more IVUS or any method of measuring the vessel diameter before doing balloon angioplasty of tibials. I think they're much bigger than we think. So I appreciate you doing an IVUS on this case. Yep.
Yeah, I think that's important. So let's use that as our roadmap. Sorry, as I freeze it here. Okay. We'll smart map that. All right. And
So
have
what Chris is
40
trying to do
balloons ready,
here is
guys.
trying to
Just-
get a complete pedal loop
Don't put your hand under
revascularization. What it means is the anterior and posterior circulation of the foot going to have a brisk flow in it. And that's a very good way of ensuring that all segments of injury zone segments of the foot is going to have direct flow to it. So it's we're just talking about your thought process, because it's a phenomenal idea to have complete revascularization of the all the segments of the foot.
And I think if we needed, if the posterior tibial angiosomal distribution was ischemic as well, I think we would go after the PT. And there's, I think we could do that either antegrade or retrograde. It looks beautiful for either. Okay, got it.
Yeah, it looks like a good case for Tammy at a later time.
Thank you. Yeah. I may have to come to your place and just get more familiar with the ultrasound guide that you guys do so amazingly. So go ahead and fluoro. Hey, younger eyes over there, keep an eye out for the balloon, please.
So Chris, you
I'm
chose
not talking to you, Tony.
the vascular track. I heard you asking for vascular track.
Yep.
Can you explain to us
And the question is,
some more about
yep.
the balloon?
And I probably should have used a 40, quite honestly, but we'll go with that. So we're going to go still with focal force, getting the ostium, and I'd really, really, hold this if you would. I'd really rather not dissect and go into that other set of questions. Fluoro for me, please. All right, go up right there, slowly, nice and slow. So again, go nice and slow. 2, 3, 4. And what I like to do is, so we chose that jihad because of, again, I don't want to dissect. To Rich's point and to everybody's point, balloon technique, whatever is focal or not, is what we're learning from the drug-coated balloon trials is that you're right, we undersize our balloons and we do them too quickly. And I think we are learning more and more to just do good balloon technique. So we're going up slowly with something that we hope won't dissect. And we're at nominal here and slightly above it. what we like to also to kind of give us an idea, to your point, Jihad, of trying to go one-to-one as best we can.
I don't know if this is a personal preference or not, but in these angulated lesions like this, if it's just a focal osteal thing, I think that what you did originally was perfect, but really there is more disease that's beyond it, so now you're kind of gaining on it. Typically, I would take the balloon from the distal popliteal and use a longer balloon, 40 or even 60, and really kind of smooth the whole transition, as opposed to trying to get little segments of it. I don't know if it really makes a big difference, but it's just technically just a difference of how one might do it. I don't know if the other guys would take a little longer balloon or not.
You know, we've learned when we see a lesion like this to just go beyond the genicular takeoff and then come back into popliteal, and it seems to do well.
I think you're right. If we had to do this again, probably at least a 40 balloon would at least made it around that curve, and may not only treat all the disease. I think we're going to get the disease here, but it may actually be more natural for the vessel and have a less risk of dissection as well.
You know what, though, Chris? You used a 40 balloon and you dissected beyond the lesion. We'd be saying, now, Chris, why'd you use a 40 balloon beyond the lesion now? So it's a lot easier.
Hey, Tony,
for us.
either way, I'm going to blame you and Jihad for this if something doesn't go right.
Chris, I want to commend you on putting a wire down the perineal artery. It takes a little bit extra time to do that, but that's a good idea. You know, you lose that perineal artery, and then you're in a whole lot of trouble.
Now, did you choose a 4.0 balloon or just a 3.5? What is this?
You know, I compromise between Ivis and Jihad.
So 3.5.
So we use a 3.5.
All right, that's acceptable.
And again, as even Jihad mentioned, you know, really, we try to go with what we would plan and then listen to the wisdom that's on the panel and take all into account. So, Flora, please.
Hey, Chris, before you take an angiogram, I guarantee you that you will not have a serious dissection here.
Man, I love a guy who puts his opinion out there. So, Jihad, congrats.
He put a Diet Coke down on it, too.
Yeah, just for full disclosure, so what if he has a dissection? What are you offering back in that guarantee?
Yeah, no, hey, Lawrence, give me...
stent. And for you, a drug-eluting stent.
Exactly. And something good there in Chicago when we get there.
But you
So
know,
be
Chris,
my agent there, Lawrence.
I gotta tell you, Chris, this is a patient that you're definitely making a difference in this patient's life, because this ulcer was going to progress to osteomyelitis, and osteomyelitis to something a lot more progressive. And once they get there, you know, amputation is waiting. So you're making a big difference for this patient right now.
There you go.
And
you feel good about yourself.
And he's a super patient. He really is. All right, so here comes the guarantee shot. Okay, hold nice and still, please. Jihad, I love you, man.
All right, great. 4.0 would have been great, but this is beautiful.
So I'll loosen my girdle here and move on to the rest of it. I should have listened to you, but that's good. So, all right, so now what we're going to do is take our NAV6. You got that ready?
You know, Chris, one more suggestion. The next injection you do, make your partner do it, man.
Yeah, no, good call. You hear that, partner?
I'm happy to do it.
Again, sometime off camera, somebody will have to give me their experience with do epidural steroid injections work and who their favorite neurosurgeon is. I'm hoping not to visit the second part of that. So, Mark, get your injection hands ready. All right. Let's, hey guys,
Ready?
you got the NAV6 right?
Yeah, we're getting ready.
Okay. And we don't have to be too careful with bubbles. All right, so we're going to put this as far down as we can in the popliteal. And then the questions are options that are on the table.
What's your
All
goal?
right, to go ahead and use the large.
What's your goal
So
for
the
this
goal-
next portion of this procedure?
And that's a place to start. One goal would be to relieve his claudication in addition to the toe ulcer. The other goal would be if this was an embolic event, and again, your point earlier, well taken, and it's healing. The other goal would be to prevent the next embolic event. With it, and it was by IVUS and everything, that, it's probably in the 2.35 range on the aneurysm. With well, we didn't show you a lot of gradu or whatever the word is for that. There's probably a better word, but a lot of plaque. And so the idea would be if we can put 8 Viabons to prevent the next one. So towards that question, I'd love your thoughts on should we even try to just treat the disease in the SFA before the aneurysm, okay? Or if not, just go straight. Does that offer any benefit? We're prepared with that with a large jet stream device, or should we just, if we're going to do that, go straight to Viabon stenting, or stop and fight another day?
That's the panel. Sonia,
Okay, get the.
you want to keep going? She's tired.
Chris, I think your lesions when you started out, if you just deal with the below-knee lesions that we looked at, the anterior tib osteal lesion, and then they looked like there was something sort of in the mid portion of the AT, and then more distally,
Yep, good point.
which is why the perineal filled the DP. I think in order to heal this ulcer, he does need inline flow. So I think you really have
Yep.
to assess whether the flow through the anterior tibial now is good enough where it's getting in line to where the target is, which is the toe, and that's going to heal the wound. You're there, you're seeing the patient. With an ABI of 0.4 and a claudicant who started developing a wound, I don't know if the popliteal aneurysm is symptomatic in that it caused an embolism which caused the wound. I guess that's the part that in my mind, I'm debating. You could always come back and fix that as well. So I think assessing the anterior tib really, which is what I think is the main vessel here, throughout the length, and make sure that you get your good inline flow as fast as the perineal's filling, should be your goal.
Was there a gradient in that SFA lesion, the proximal SFA lesion, where it gets a
Tony,
little
to
bit-
be honest, there was a lot of plaque by IVUS, and I didn't do a gradient. I would believe that there is, and I would think that the ABI and the PVRs
It's probably from
showed that
that.
there was definitely, from that, there was a drop-off across that lesion significantly.
Yeah, so that makes sense then to treat that if that's the inflow. I mean, obviously, I'd want to know something hemodynamic from it, but an ABI of 0.4
Yep.
doesn't come just from that single segment disease. It's got to be from multi-segment disease, including that diffuse to disease SFA. So the multiplication or addition of those vascular drops. So even if you didn't measure a gradient there, I bet that the mid SFA lesion's important. You have 3 minutes and 53 seconds to do whatever it is you're going to do.
All
No
right, well, why don't
pressure.
I tell you what we're going to do then? None at all. So let's go ahead and put our NAV6 down. Tell me when you see it, guys.
That's actually true.
There it is. You're there.
Let's make a road map here.
Right.
So here we go. Go ahead. So for the sake of our patient, we're not going to try to get everything that we're going to get done in 3 minutes and some odd seconds because I don't think that would be good for him. I will tell you what we're going to do. We're going to put a NAV6 as far distally as we can there, okay? We're going to take your advice, Sonia, and at the end of this, once we're off camera, make absolutely certain that the anterior tibial flow is maximized. We did IVUSat, and it didn't look that bad in the spot that I showed you on the initial pictures that we thought we were going to have 2 lesions for sure. It didn't look that bad. So if it doesn't look that bad, we have straight line flow, we're going to stop with what we've done in the anterior, but we'll assess that. And I think what we're going to do is put a NAV6 here, treat the SFA, and then probably Viabon, but we're going to consider that carefully. What we sometimes do with the Viabon is put a supera stent inside of that because then you have the radial force of a supera stent inside the cover stent. So the cover stent gets the aneurysm. The supera stent inside of that will allow the flexion, but it won't allow any infolding, okay? And so what we would do then is put a 7/0 separators inside of the 8/0 Viabons. Again, just a thought, but we have done that several times.
Yeah, Chris, it's Rich here. I would
Yes.
agree with that completely. We have a series of patients now that we've treated popliteal aneurysms with Viabons, and the only one that clotted on us was the one that we didn't put a superior inside. So, I just think they kink too easily at the knee.
Now, which ones are anterior tibial wire? Right there, here. That's the bare wire there, right? Make sure it's a bare wire.
The wires here, yes.
That's in your hand. Okay, so I'm going to take the anterior tibial wire. Okay. Okay. So the anterior tibial wire's out. Okay, fluoro, please. All right. Nice, Ben. Thank you. Okay. And fluoro, save that, please. So what's our time there, Jihad, so that I kind of get a plan for you guys?
So Chris, we just saw you deploying a NAV6, which is a phenomenal idea. You know, having been in a practice with young partners, you always have to go and snare it back out for them after they use the wrong wire. Can you tell us about the right wire for this filter?
Yeah. So I don't know if you heard me whispering to Mark, but we're, and not only friends or partners, we look for this, the stripes on the back of this. And there are only two wires that can be used for the NAV6. The one is the 019 proprietary wire. The other off-label, and I want to say that clearly, is the Viper 017 tipped wire that if you're doing CSI orbital atherectomy, for example, and you think you need distal protection, that wire will work with the NAV6. But your point is very good, Jihad, that you've got to make sure you're putting the NAV6 on the right wire and that it's an exchange length wire before you do anything, okay?
Yeah.
So, that's what we're going to do here. So why don't we go ahead and...
Chris, thank you so much, man. That has been a beautiful morning. Thank you for starting the day. Phenomenal for us. Unfortunately, we have to leave you, my friend, but we will be seeing you again about noon, hopefully. Thank you for everything, Chris.
Thank you guys very much for all your help.
Good job, Chris.
Thanks. Great job.
All right, see y'all.